Hi, I'm Professor Gavin Giovannoni, the Professor of Neurology at Barts and the London School of Medicine and Dentistry, and I'm based in Whitechapel in the East End of London in the United Kingdom.
The following audio is part of a certified educational activity titled Highly Effective Disease-Modifying Therapies for Multiple Sclerosis. When and in whom should they be used? Access the entire activity and complete the post-test at www.peerreviewpress.com/activity-GAW. Downloadable slides and practice aids are also available.
I'm here to talk to you today about the treatment of relapsing multiple sclerosis. MS is considered by most to be an autoimmune disease of the central nervous system, and in the past we classified it as a white matter disease, but the evidence now suggests that it's a whole brain disease and that we see a lot of pathology involving the deep grey and the superficial or cortical grey matter. The pathophysiology of MS is very complex, and in part it involves the migration of inflammatory cells into the central nervous system across the blood-brain barrier. This results in inflammatory focal lesions that are responsible for demyelination, axonal transection, and eventually axonal and neuronal loss, and we get gliosis at the site of the lesions. The lesions tend to concentrate in an area of the white matter, and depending where they occur, they will cause different presentations, and that's why we get such varied presentations in multiple sclerosis. Since the emergence of disease-modifying treatment, we've come a long way forward in the treatment of MS. Prior to 2010, we only had 6 licensed disease-modifying therapies approved by the regulatory authorities to treat MS. There were 3 interferon beta preparations, glatiramer acetate, Daclizumab, and mitoxantrone. However, since 2010, the number of FDA-approved therapies has more than doubled. And more importantly, we now have access to a whole range of treatments with different attributes. We have 3 new monoclonal antibodies, Alemtuzumab, Daclizumab, and Ocrelizumab, which are the most recent additions to our therapeutic armamentarium. So the goals of treatment of multiple sclerosis vary depending where you are in the world. And we've now adopted an approach called treat to target, which we've adapted from the rheumatology field. And we try to now render people free of activity. In the sense, we like to have no evident disease activity, and this means we would like to reduce or eliminate all relapses, decrease all focal MRI activity, that's new, and enlarging T2 lesions, and if we do use gadolinium, to suppress all GAD-enhancing lesions, with the aim of slowing down or delaying disability progression. And more importantly, we're trying to prevent brain atrophy and all the associated problems that go with end organ damage. So what is a high-efficacy therapy? So unfortunately, we don't have any consensus criteria to say this treatment is high efficacy, this is moderate, and this is low efficacy. I wish we did have, because it would make it a lot easier. And so I sit on a committee for the Association of British Neurologists, and we specialize in multiple sclerosis. We've divided up the disease-modifying treatments into 2 tiers. Those with moderate efficacy, they have an average relapse reduction of between, say, 30 and 50% compared to placebo. And then we have the high-efficacy DMTs, and the average relapse reduction there is well over 50%. Now, there are limitations to the ABN criteria. When we set them up, we didn't make a distinction between relapse reduction relative to placebo or in the newer drugs compared to an active comparator. We also didn't have the ability to try and adapt because a lot of the trials have used 3-month confirmed disability progression, whereas others have used 6-month confirmed disability progression. And the other thing we didn't incorporate into our decision making was the impact of these therapies on end organ damage. So a large number of phase 3 trials now are routinely collecting brain volume, and we get brain atrophy rates. And my personal opinion is we really need to put that into the mix, because to be a high efficacy therapy, you really have to have an impact on brain atrophy rates. So the kind of schema we think about is if phase 3 data was compared to placebo, the relative reduction needs to be way over 50%. Whereas if you were compared to a established disease-modifying therapy above 40%. And in addition to that, you have to have greater than 40% reduction relative to the placebo of either 3 or 6 month confirmed disability progression, whereas against an active comparator, you just have to show a reduction in disability progression. And my personal opinion is we need to also add brain atrophy in, and the current thinking in the field is you have to bring our brain atrophy rates down to within the normal range, and that's less than 0.4% per annum. So we now have 4 monoclonal antibodies that fulfill this pragmatic definition of a high efficacy therapy. The first is Daclizumab. This targets VLA4, the ligand for VCAM1, and by blocking the VLA4 VCAM interaction, we prevent trafficking of B and T lymphocytes into the central nervous system. The second monoclonal is Alemtuzumab. This targets the CD52 antigen that is expressed on leukocytes. The antibody binds to CD52 and depletes leukocytes by 2 mechanisms, mainly antibody-dependent cellular cytotoxicity, and secondly by a bit of complement activation. The third antibody is Daclizumab. This targets the CD25 antigen, which is the high affinity IL-2 receptor that's mainly expressed on activated and T-regulatory T cells. The fourth agent is Ocrelizumab. So this is a new anti-CD20 monoclonal antibody, and this targets the CD20 antigen that is expressed on B cells, and this is a depleting antibody and works by depleting CD20 positive cells. Now, Daclizumab is the first monoclonal antibody to be licensed in multiple sclerosis, and this was a real game changer in the sense that it took the treatment in terms of no disease activity to a new level. So it reduces the annualized relapse rate by close to 70% in the overall population that was studied. It also was very, very effective at switching off focal MRI activity, and also had quite a marked effect on delaying disability progression. Now, Daclizumab actually is a very well tolerated drug. Apart from a small population of patients that develop infusion reactions, these typically occur on the 2nd, 3rd, or 4th infusion, and are usually limited to patients who develop neutralizing antibodies to the drug. Once you get through the first 6 months, it's extremely well tolerated and is given as monthly infusions. There was initially a report of some patients developing abnormal liver function tests, and so we have to check liver function tests initially. But I suspect that wasn't due to Daclizumab, and that may have been due to just comorbidity, potentially autoimmune hepatitis that occurs in some patients with MS. Unfortunately, the drug blocks trafficking of lymphocytes into the central nervous system, prevents immune surveillance, and the main risk of this drug is progressive multifocal leukoencephalopathy, and that risk seems to be limited to the JC virus positive population, which is why we now test for the JC virus status before starting or making a decision to start the drug. So the second agent is Alemtuzumab, and this was compared to an active comparator, interferon beta-1a, 45 micrograms subcutaneously 3 times a week, and there were 2 studies. This is the only drug that's been tested where the 2 trials actually answered different questions. So the first study, the KMS1, compared Alemtuzumab to interferon in naive patients, and it reduced annualized relapses by 55% compared to interferon. In this trial, there wasn't a positive outcome in terms of sustained disability progression, mainly because the patients on interferons actually didn't progress very much. In the KMS2 study, Alemtuzumab was also compared to interferon, but in this population, all patients had to have had a suboptimal response to a platform therapy. This was typical either interferon or Glatiramer, and they had to have breakthrough relapses to get into the trial. They were then re-randomized either to Alemtuzumab or to interferon, and in this trial, the annualized relapse reduction compared to interferon was 50%, and this was positive with a 42% reduction in 6-month sustained disability progression. The profile of Alemtuzumab in terms of its AE profile is quite complicated. So I like to break it up into different phases. So almost everybody who receives the therapy has infusion reactions. And that's because it's a cell lysis syndrome. When you give the drug, you lyse the cells, and they release their contents, and they get infusion reactions. And we limit those by giving patients corticosteroids with each infusion and pre-dosing them with antihistamines. For the first few weeks after the therapy is given, there's a leukopenia, And then the innate cells come back first, and the B lymphocytes, the T lymphocytes repopulate later on. And during the period where people are leukopenic, they're at risk of infections. And so we put people on antivirals to cover viral reactivation, like herpetic lesions, and we warn them about infections so we can treat them proactively. And in our series at our own hospital, about 30 to 35% of people get infections in those first few weeks to months after receiving Alemtuzumab. Once the immune system starts to reconstitute, we start getting the main adverse event profile of Alemtuzumab, which is the so-called secondary autoimmunity. And this typically occurs about 12 to 18 months after the last course of the treatment. And that is the real issue with this drug, because most of those secondary autoimmune things need to be treated. The big one is autoimmune thyroid disease, and so we measure thyroid function tests every 3 months. And the big ones are ITP, immune thrombocytopenic purpura, and for that we need to do monthly blood counts to look for platelets, because if we do show a drop in platelets, we need to proactively treat those patients to prevent life-threatening complications. The other big one is autoimmune glomerulonephritis, usually of the good pastures phenotype. We have seen some membranous glomerular disease as well, and for that we have to monitor urine tests as well as renal function every month. And this is one of the big issues with Alemtuzumab, that patients have to come up for monthly monitoring. So Alemtuzumab can be de-risked slightly. So one of the things we have to do prior to giving Alemtuzumab is to make sure people are safe to receive it. So we have to screen all our patients for TB, make sure they've got immunity against varicella, so prevent them getting chickenpox. So the next drug is Daclizumab. And so this has just recently been licensed. And we have 2 trials. The first was the SELECT study, and this is where Daclizumab was compared to placebo, and it reduced annualized relapse rate by 54% and reduced confirmed disability progression by approximately 60%. In the DECIDE study, the second phase 3 trial, Daclizumab was compared to intramuscular interferon beta-1a, 30 micrograms once weekly. And in this active comparator trial, it reduced the annualized relapse rate by 45% and delayed 6-month confirmed disability progression by 27%. I must point out for the purists listening to this that the 6-month confirmed disability progression was a tertiary outcome. The secondary outcome was 3 months. So Daclizumab has a relatively specific adverse event profile. The drug is extremely well tolerated. Most people didn't really complain of injection site reactions, which are very uncommon, less common than you get with interferons. It reduces the lymphocyte count by between 10 and 15%, so we didn't see an opportunistic infection signal in the trial. There was, however, a higher rate of common infections that became serious compared to interferon. These tended to be pharyngitis or skin infections, and you just need to warn your patients that if they do get an infection, they shouldn't ignore it, and they should get it looked at and treated if necessary. The one thing we did pick up there, however, is that about between 1 and 2% of patients develop abnormal liver function tests, and sometimes this becomes more severe. And we unfortunately had a couple of patients develop a auto-inflammatory hepatitis. And so one of the requirements for Daclizumab is monthly liver function test monitoring, so we can stop the drug and initiate treatment if there is any evidence of abnormal liver function tests. The other thing that we picked up is patients can develop a hypersensitivity skin reaction, and this occurs in about 2% of patients, and if that occurs, the drug has to be stopped as well. Those hypersensitivity skin reactions tend to be steroid responsive, so if picked up early and managed, they're usually reversible. Again, because it's a drug that affects the immune system, we also, in our practice, do exactly the same de-risking of the drug at baseline. We screen patients for tuberculosis, hepatitis, and we make sure all their baseline bloods are clear. Now, the final of the 4 monoclonals is Ocrelizumab, and this is the most recently licensed drug. And there were 2 phase 3 trials that were identical in the relapsed remitting population, and the drug was compared to interferon again, and it reduced annualized relapse rate by 45% and had a impact on disability progression of 40%. This drug also had a very, very profound effect on MRI activity, suppressing both new and enlarging T2 lesions and reducing gadolinium-enhancing lesions by over 90%. Ocrelizumab was remarkably clean in the relapsing trials. If anything, the side effect profile was superior to interferons. The main thing, again, because it's given as an intravenous infusion and you're getting B-cell lysis, is that there is a significant incidence of infusion reactions. These tended to be mild. There were very, very few moderate or severe reactions. And again, we manage these by pre-dosing patients with corticosteroids. Again, because Daclizumab is a depleting drug, we also do the infection screen at baseline to make sure patients aren't, for example, hepatitis B positive or have underlying tuberculosis. I must point out that in the primary progressive or oratoria trial, there was a malignancy signal. There were 13 cases of malignancy in the trial, 11 in the Daclizumab arm and only 2 in the placebo arm. That's a 5.5 to 1 ratio because the randomization was 2 to 1. These tended to be solid organ malignancies, but there were 6 breast cancers. So to try and put these high-efficacy monoclonal antibodies into perspective, I think the best way to do this is to give you 2 short case stories to show you how they can be used and the issues that need to be addressed in clinical practice. So the first patient is a patient called Marcus, and he's a 45-year-old divorced African American. He's a father of 3 children from his previous marriage. He has 2 daughters and a son, and their ages range from 6 to 14. He currently owns and operates his own company, an office cleaning service, so he's very active on a day-to-day basis. And another thing in his history is he's a smoker, smoking about 20 cigarettes per day. So in February 2014, when he was 42 years of age, he had an episode of transverse myelitis. He presented with mild numbness and weakness in his right leg. At that time, he did not seek medical attention because he was preoccupied with work commitments and made a very good recovery. But he still noticed that when he went for a walk, after about 500 to 1,000 meters, he would develop a limp in his leg, so he hadn't made a full recovery. He then, in August 2014, presented to the emergency room with a 2-day history of gradual visual loss in his left eye. This was accompanied by retroorbital eye pain, and he had decreased color perception in that eye. At that time, the emergency physician ordered an MRI brain and spinal cord. And that was based on his recent history of numbness and weakness in his right leg. And he was treated with high-dose oral methylprednisolone on the basis of him having an episode of optic neuritis, and he was referred to a local neurologist. Marcus's brain MRI showed multiple high-signal T2 lesions compatible with demyelination, and on his spinal cord he had a large T2 lesion with swelling of the cord. Marcus' neurological examination was abnormal. He had some mild pyramidal weakness in his right leg, reduced vibration sense in both feet in the great toes, and he had upgain plantar response. He had evidence of optic neuritis, and he had a pale disc, abnormal color vision, and an afferent papillary defect. When he was assessed, he did have some fixed disability, and his EDSS score was rated at being 2. He's also an African American, which puts him into a poor prognostic profile. He's male. He's relatively old. He's got a very short interval between his 2 relapses. He's got some fixed disability. He's got a high T2 lesion load, and he's also got spinal cord disease. And you could also throw in smoking. So he's got a pretty bad prognostic profile. So you're not going to leave this individual patient without offering him a treatment. And I think, based on his profile and what we expect his disease to do in the future, I think this is a typical candidate and a very easy candidate for a high-efficacy therapy. So his neurologist actually took this line of thought and counseled him about his long-term prognosis and offered him a high-efficacy therapy. This was in 2014, so at that time, Daclizumab was really the only high-efficacy therapy available, apart from mitoxantrone. And as you know, most of us have stopped using mitoxantrone because of its side effect profile. So Marcus was counselled. He had some baseline blood tests done, which included a JC virus antibody status test, and all his baseline bloods were normal, and he came back as being JC virus antibody negative. So I think it's very, very important now to include JC virus status testing as part of the baseline investigations in patients with active disease, because it does influence decision making. But how you tell people about the risks associated with JC virus testing is very, very important. When we first got the assay in our clinical setting, we used to provide patients with a 3-page information sheet regarding the JC virus risk and the risk of PML. And when they came back a few weeks later, they had no recall of their risk. More than 80% of patients couldn't tell us what their risk was. So we simplified it by giving them a simple infographic that literally takes 1 minute to explain it. We ring their risk, give it to them, and they can read on the back of the information sheet about why we test, about PML, and what Daclizumab is. And when we put out this infographic, recall in terms of their risk was well over 85% when they returned a month later for the next infusion. So it's how you tell the story that's very, very important in clinical practice. Now, Daclizumab in my setting is not used that often as a first-line agent. We usually limit it to patients that have what we call rapidly evolving severe multiple sclerosis. And Marcus would be one of those patients who would fulfill our local criteria for Daclizumab. My personal opinion is the antibody index does help de-risk the drug, particularly if people are antibody positive on therapy. But nowadays, when we're starting naive patients and we find somebody who is JC virus antibody positive, we tend to push them towards one of the other therapies. I think now that we have alternatives to Daclizumab, it's hard to justify using it in place of the other alternatives. So Marcus commenced treatment with Daclizumab. We also try to manage him holistically in the sense that we would push him towards a smoking cessation program. There's clear data out there now showing that if you have MS and you continue to smoke, okay, your disease progresses more rapidly. And at the same time, we would also counsel him regarding other relevant lifestyle issues, particularly around exercise, making sure we screen him for comorbidities and manage those if they emerge. Since commencing treatment, he undergoes monitoring at regular intervals, and he has remained seronegative, and reassuringly, he has had no clinical or radiological signs of disease activity. In other words, he's been NIDA on Daclizumab. Now, Marcus's scenario occurred in 2014, where we really had only one option. Now, in 2017, we've got the other 3 drugs. We've got Alemtuzumab, Daclizumab, Ocrelizumab. And so in this current environment, we would have to really counsel Marcus about all 4 agents. And so because he's JC virus negative, he's eligible for all of these agents. And which one would we choose? Well, that will depend on other factors. For example, he's a busy person running his own company. Does he want to come up for monthly infusions? Does he want to come up for monthly blood monitoring? Does he want to self-administer? Does he like the idea of a 6-monthly infusion? All these issues will play into the decision-making around an individual patient. So I'm not going to say one drug is better than the other. We'd have to personalize the decision around these 4 monoclonals to give him the best option that suits his lifestyle. Now, the second story is of Kathleen, and she has relapsing-remitting multiple sclerosis. She's a 32-year-old woman with Irish descent. She's employed as a postal worker since the age of 23 and has been walking the same delivery route for over 5 years. She's married and is a mother of an 8-year-old son. So in April 2013, Kathleen missed 3 days of work due to an episode of ataxia, diplopia, and headache. She put it down to migraine because she has been a migraine sufferer since her teenage years, and she's had auras in the past. She returned to work after the severity of her symptoms waned, and they completely resolved about 10 to 14 days after the onset. However, about 20 months later, in early January 2015, she experienced numbness in her left big toe, and it extended up her foot, and it caused her to trip while walking her normal delivery route. In August 2015, she experienced burning pain in her left shoulder for approximately 14 days, which forced her to carry her mail bag on her right shoulder. In February 2016, she then went to her family doctor complaining of double vision, vertigo, and numbness and weakness in her left leg. Her doctor thought that she may have some kind of inflammatory condition and prescribed oral prednisone and arranged for her to have an MRI of the brain and spinal cord, and was subsequently referred to a neurologist for an opinion. So after her presentation to her primary care doctor, Kathleen finally got seen in a neurology clinic in March 2016. At this stage, her previous symptoms had almost completely resolved. And based on her prior history and her MRI findings that showed lesions compatible with multiple sclerosis, Kathleen was given a diagnosis of multiple sclerosis, and her baseline EDSS was rated at being 1, so very early on in the course of the disease. The MRI findings were discussed with Kathleen, and her neurologist was concerned about the number of lesions on her brain MRI, as well as the presence of a cervical spinal cord lesion. As you know, it's a poor prognostic sign, and she was recommended to go on to disease-modifying therapy. So based on prior history, MRI findings, and the fact that she has multiple sclerosis with an EDSS of 1, Kathleen was initiated on a platform therapy, glutaric acetate, 40 milligrams 3 times a week. That was in April 2016. She was subsequently switched to oral dimethyl fumarate, 240 milligrams twice daily in July. And this was because she was really having problems with injection site reactions. She had had quite large lesions and wanted to switch to an oral medication really for tolerance and adherence reasons. Unfortunately, in November 2016, Kathleen experienced a spinal cord relapse consisting of numbness, weakness in the legs, then arms, and even had difficulty breathing. She was admitted to an intensive care unit with quadriparesis and was treated with both high-dose intravenous corticosteroids and had to have plasma exchange. An MRI also showed new activity in her spinal cord, which actually extended high up to affect the upper cervical region, which obviously affected her breathing. She made a remarkably good improvement over 6 weeks, but went to an EDSS of 2.5. Now, clearly, Kathleen's neurologist was very concerned over the level of disease activity she had experienced since her MS initially manifested 4 years ago. And this latest severe exacerbation with some residual disability really put her into a high-risk category. And he was very concerned about her long-term prognosis. Clearly, the patient herself, Kathleen, was concerned about the potential for developing fixed disability in the long term, and she was extremely anxious about whether or not she'd be able to continue working and being a mother, looking after her son. And so her request to a neurologist was, what can you do to control my disease as quickly as possible? And I'm willing to accept any risks associated with the treatment. So this is how a patient can go from the environment of not wanting that much risk and going on to a moderate efficacy platform type treatment, and then having a bad relapse and looking at her future and saying, goodness, give me anything, I just want my disease under control. And so the neurologist did a baseline workup. Like I said before, he had to risk profile her, did all her liver function tests, screened for VZV, did a TB screen, made sure she wasn't HIV or hepatitis positive, and checked her JC virus antibody status, simply because Daclizumab would be an option. And that unfortunately came back as being positive with a high index of 2.6, which really excludes Daclizumab as a treatment option in Kathleen's options. And so given her JC virus titer and the risk profile, she had the option of choosing the self-administered Daclizumab and Alemtuzumab, and based on the data in the CARE-MS2 having a clear impact on both relapses, disability progression, and what was really appealing to her was actually the short courses, just the 5 infusions in year 1 and the 3 infusions in year 2, without having to have further infusions after that, drove her to choose Alemtuzumab. So she was treated with Alemtuzumab. So ultimately, Kathleen and her neurologist agreed, and she opted to commence on treatment with Alemtuzumab and underwent the 5 infusions in January 2017 without any incident. She was pre-dosed with steroids and had her antihistamines and tolerated the infusions very well. I'm told that she was very good in terms of her adherence to the Listeria diet, and she didn't have any complications. She continues now to be monitored clinically and monthly with regard to her full blood count and liver function tests, as well as her renal function tests, and is doing well. So to conclude then, I hope I've convinced you that there's a place for high efficacy therapies in the management of multiple sclerosis. And there's clearly a group of patients with high activity that would benefit from these treatments as early as possible. The first case, Marcus, was a first-line treatment. And so for the first time, we now have this opportunity of flipping the pyramid and offering our patients that have a poor prognostic profile with active disease the most effective therapies first line. I've also said to you that we don't have a current consensus definition for what a high efficacy therapy is, but I think based on our contemporary criteria, the 4 monoclonal antibodies, Alemtuzumab, Daclizumab, Natalizumab and Ocrelizumab, all fulfill at least a working definition of a high efficacy therapy. In addition to the prognostic profile and the high efficacy therapy, there are many other factors that need to be taken into account, and both these cases illustrate that. There are things around adherence to monitoring, the ability to be monitoring in terms of work, risk aversion. Some patients don't like to be on long-term immunosuppressive therapies. Some people like to travel to exotic places where they get exposed to new infections. So there are a lot of other factors that need to be taken into account when choosing a treatment. And one of the things that's very, very important that hasn't been highlighted by these 2 cases, but is the elephant in the room, is that MS is a disease mainly of women, usually in their childbearing years, and a big issue is starting or extending a family. And so pregnancy or family planning is a big issue. And some of the advantages of the monoclonals is that they can be used quite intelligently in that setting to try and control the disease activity and allow women to fall pregnant without any problems. Thank you very much.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerviewpress.com/GAW. This activity is supported by independent educational grants from AbbVie and Sanofi Genzyme.